Imagine a surgeon taking a muscle from your leg, wiring its blood vessels into your arm, and then taking a nerve from your chest.
Right, a nerve whose only evolutionary job has been to help you breathe.
Exactly. Taking that breathing nerve and plugging it into that transplanted leg muscle, and then somehow your brain just figures out how to use that chest nerve to make your hand move.
It is honestly wild to even think about.
It really is. Welcome to the deep dive. Today, we're looking at the ultimate biological wiring diagram. We have a stack of incredibly detailed clinical texts in front of us, and they cover a pretty devastating medical issue, traumatic brachial plexus injuries.
Yeah, and the mission today is to explore this dense network of nerves controlling our upper limbs. And really, the high-stakes, almost science fiction level surgical chess match that's required to fix it when it violently breaks.
It really is a remarkable field of medicine.
Oh, absolutely. Because behind the dense anatomical terms and the surgical algorithms we'll be discussing today, there are life-altering injuries. I mean, these are scenarios that demand an unbelievable level of surgical ingenuity.
Right, because the biological structures we're talking about are, they're delicate, complex, and highly unforgiving when damaged. So let's start by looking at who is actually facing this reality.
The statistics are pretty grim, honestly.
They really are. The clinical texts outline something called Narciss's rule of 770s to describe the epidemiology. It's like this cascade of statistics. So 70% of these injuries are from road traffic collisions.
And then 70% of those involve motorcycles or bicycles.
Right. And 70% of those riders have multiple other injuries. Then it gets into the anatomy.
And back.
70% are supraclavicular, meaning the injury happens above the collarbone.
Which is the worst place for it to happen, really.
Yeah, because 70% of those have at least one nerve root completely torn away from the spinal cord. And 70% of those avulsions involve the lower roots.
And finally, the last 70%, they're associated with severe chronic pain.
It paints a very stark picture of high-energy trauma. We're primarily looking at young males, usually 15 to 25 years old, whose lives are altered in a fraction of a second.
Yeah, the statistics reflect the brutal biomechanics of a very specific type of crash. When a motorcyclist is thrown from their bike, the exact way their body impacts the ground dictates the pattern of those nerve injuries.
Okay, let's unpack this. Before we get to the destruction, we need to visualize the architecture of this system. Think of the brachial plexus like the main electrical breaker box of a house, but, incredibly complex.
That's a great way to look at it.
You have the main power lines coming in from the street, that's your spinal cord. But before that power can turn on a specific lamp in the living room or like the blender in the kitchen, it has to go through this highly organized bundling and routing system.
Right, the power leaves the spine through the neck, bundles together, splits apart, bundles again, and eventually becomes the individual wires running down your arm, forearm, and hand.
The breaker box analogy works perfectly here.
It really does.
Why?
Especially because of how systematically the nerves reorganize themselves. The anatomy here is famously intricate. It's divided into 5 distinct zones. First, you have the roots, emerging from the cervical spine levels C5 through C8, and the first thoracic level, T1.
And those roots don't just stay separate, right?
No, they quickly merge into trunks upper, middle, and lower. Then, as those trunks pass behind the collarbone, they split again into anterior and posterior divisions.
It's just constant splitting and merging.
Exactly. Deep in the armpit, they merge once again into cords. Those are named the lateral, medial, and posterior cords based on how they wrap around the main artery of the arm. And finally, they branch out into the terminal nerves, like the median, ulnar, or radial nerves that actually command the muscles.
So roots, trunks, divisions, cords, branches, it's like a massive highway interchange. Lanes are constantly merging and splitting to ensure that every muscle gets signals from multiple spinal levels.
Yeah, redundancy is key. But the sources mention this architecture can actually vary from person to person.
Right. They use terms like a prefixed or postfixed plexus, which sounds like a grammar lesson, but it's anatomy.
Yeah, there is a surprising amount of anatomical variation. Sometimes the entire network shifts up a level, pulling a major contribution from the C4 nerve root above. That is a prefixed plexus.
Or it shifts down, pulling heavily from T2, making it postfixed.
Exactly. And this architectural shift creates a complex puzzle for neurologists because when they're examining a patient, a symptom might point to damage in one specific nerve territory based on standard textbooks.
But because of the patient's unique biological wiring, the actual structural damage is entirely elsewhere.
Right, it makes diagnosis incredibly tricky.
And looking at the roots themselves, the sources emphasize a physical separation at the very base of the system. Spinal nerves arise from two separate pathways right where they exit the cord.
That separation is absolutely critical for understanding the symptoms of these injuries. You have the ventral root, which sits toward the front of the spinal cord. It carries only motor signals.
So those are the outgoing commands from the brain to the muscles.
Right. Then you have the dorsal root, sitting toward the back, carrying only sensory signals from the skin and joints back into the central nervous system.
And they merge together just outside the spinal cord to form a mixed spinal nerve.
Exactly. So if an injury selectively damages the ventral pathways, a patient might have profound weakness, but perfectly normal sensation.
Wait, I'm picturing the neck and the shoulder area. This is heavily protected real estate. You've got thick neck muscles, the spine, the rib cage, and the collarbone acting as a shield.
It is heavily fortified, yes.
Right, so a nerve root doesn't just pop out. If these nerves are buried deep in the neck and protected by the collarbone, how much force does it actually take to rip them out? What is physically happening to the body to cause that level of destruction?
It requires an immense amount of mechanical force. As we noted with Naraka's rule, the most common mechanism is traction, which is violent stretching. Picture that motorcyclist being thrown. They land forcefully on the point of their shoulder, driving the shoulder violently downward toward the pavement. At the same exact moment, the momentum of their body and the heavy weight of their helmet whips their head and neck in the complete opposite direction.
Wow. So the neck goes left, the shoulder goes down and right, and the nerves bridging the two are pulled tight like a rubber band.
Exactly. Pulled tight until they hit their tensile limit. The collarbone, rather than protecting them, can actually sometimes act as a fulcrum that the nerves are bent and stretched over.
That sounds awful.
It is. The traction stretches the tightly packed nerve bundles until they rupture mid-substance. Or worse, they are completely avulsed, meaning the roots are literally ripped out of the spinal cord itself.
And it's not just traction, right?
No, there are also crush injuries, where the plexus is squeezed between the collarbone and the first rib, and penetrating injuries from sharp trauma, like glass or chainsaw accidents. But high-energy traction is definitely the dominant mechanism.
And the angle of that crash determines which cables snap. So if the top part of the plexus takes the brunt of the hit, the C5 and C6 roots, the patient presents with something called Erb's palsy, or Erb-Duchenne palsy.
Yeah, those upper roots are primarily responsible for the muscles around the shoulder and the upper arm. They control shoulder abduction, which is lifting the arm away from the body, and elbow flexion, like doing a bicep curl.
They also control the muscles that turn your palm upward.
They do. So an upper trunk injury leaves the patient's arm hanging straight down, rotated inward, with a complete inability to bend the elbow. Look up the classic waiter's tip posture.
But if the angle of the crash pulls the arm forcefully upward, say, catching a tree branch while falling, or taking a very specific upward impact, the lower roots, C8 and T1, take the damage.
Right, and that results in Klumpke's palsy, which manifests completely differently. The patient loses control of the intrinsic muscles of the hand.
The contrast is striking, isn't it?
It really is.
Yeah.
With a lower root injury, the patient might have perfect shoulder and elbow movement, but their hand is rendered functionally useless. They lose the fine motor control, the ability to spread their fingers, and all grip strength.
And a lower root injury often brings Horner's syndrome into play, which is fascinating because we're talking about an arm and hand injury, but suddenly the doctor is looking at the patient's face, checking for a drooping eyelid and a constricted pupil.
Yeah, the sympathetic nerve chain gets caught in the crossfire.
Right. It is a profound diagnostic clue.
It is. The sympathetic chain, which controls those involuntary facial functions like pupil dilation and sweating, runs vertically right alongside the lower roots of the brachial plexus at the base of the neck.
So if the trauma is violent enough to physically avulse the T1 root from the spinal cord,
the surrounding tissue damage almost invariably wipes out that local section of the sympathetic chain as well.
wow. And of course, there's the panplexus injury involving C5 through T1, all the main power lines.
The worst case scenario.
Yeah, the statistics say up to 75% of these high-energy supraclavicular injuries wipe out the entire network, leaving the patient with a flail, completely insensate arm. It just hangs there, completely numb and paralyzed.
Which puts the trauma team on a very difficult path. Once a patient is stabilized and the life-threatening injuries, like collapsed lungs or internal bleeding, are managed, the surgical team has to map the exact extent of the nerve damage.
And they have to do this without immediately opening the patient's neck up.
Right, they have to play detective. They look for physical clues first. If the limb is completely pulseless, they know the massive subclavian artery was sheared right along with the nerves.
But one of the most interesting clues comes from a standard cervical spine X-ray. They look for fractures on the transverse processes. Those are the little bony wings sticking off the sides of the neck vertebrae.
The biomechanical connection there is vital. Those little bony wings are anchored tightly to the nerve roots by deep fascial tissue.
So if the X-ray shows that a transverse process is fractured and displaced,
It operates like a drywall anchor being ripped out of a wall.
that is such a vivid image.
It is a massive structural red flag that the corresponding nerve root attached to it has been violently avulsed from the spinal cord. They also perform a physical exam looking for a tenal sign by tapping along the path of the nerves in the neck.
Tenal sign being that electric tingling sensation you get when you tap a damaged nerve, kind of like hitting your funny bone.
Exactly. If they tap the neck and the patient feels the tingling shoot down the arm, it means the nerve is damaged, but still structurally continuous.
But if Tinals is completely absent in the neck, it suggests the nerve has been ripped out from a much higher, deeper point, likely right at the spinal cord. So there is literally nothing left in the neck to tap.
Correct. To confirm that, they bring in advanced imaging. Historically, they relied heavily on CT myelography, injecting contrast dye into the spinal fluid.
They are looking for pseudomeningocele. When the root is yanked out of the spinal cord, it leaves a literal hole in the protective lining of the spine.
And the cerebrospinal fluid leaks out into the surrounding tissue, creating a small pocket or sac.
Right, the dye fills that sac, and on the scan, it looks like a blowout in a tire.
It is indirect, but highly suggestive evidence of an avulsion. Today, however, the gold standard for visualizing this is a specialized MRI using Fiesta sequencing.
Fiesta is an acronym for a high-resolution scan that provides incredible contrast between the spinal fluid and the nerve tissue.
It is sensitive enough to allow the radiologist to visualize the tiny, thread-like individual nerve rootlets as they span the gap from the spinal cord to the exit hole. They can visually confirm if the cables are still plugged into the mainframe or if they are floating loose.
Which is amazing technology. Once the imaging confirms the structural damage, they have to figure out if the wires that are left intact can actually carry an electrical signal. This involves electrophysiology, EMG, and nerve conduction studies.
This is where the biology gets fascinating. The clinical texts explain that when a motor nerve is cut off from its cell body in the spinal cord, it undergoes Wallerian degeneration.
Right.
The cellular mechanism of Wallerian degeneration is relentless. A nerve axon is essentially a very long biological wire, but it relies entirely on the cell body located in the spinal cord for its metabolic survival.
So if the wire is severed, everything downstream of the cut gets starved.
Within a matter of days, the internal structure of the axon collapses, the myelin insulation breaks down, and local immune cells macrophages sweep in to clear away the dead debris.
Now, here's where it gets really interesting. When the electrophysiologists test the sensory nerves in a patient with a preganglionic injury, meaning the nerve root was ripped entirely out of the spinal cord, they find something called the SNAP paradox.
Yes, SNS stands for sensory nerve action potential.
The machine shows that the sensory nerve running down the arm is still conducting electricity perfectly. The waveform on the screen looks totally normal, but the patient's arm is completely numb.
It is one of the most striking paradoxes in neurology. You have a structurally sound, electrically active wire, but zero sensory perception.
I mean, how does that even happen?
To understand why, we have to look closely at the biological architecture. Earlier, we noted that the cell bodies for motor nerves live inside the spinal cord, so an avulsion kills them.
Okay.
But the cell bodies for sensory nerves are clustered together in a structure called the dorsal root ganglion, or DRG.
And the DRG sits just outside the spinal cord, in the little bony canal where the nerve exits the spine.
Exactly right.
Yeah.
Because the DRG sits just outside the cord, a preganglionic avulsion, a tear, right at the surface of the spinal cord, disconnects the entire sensory apparatus from the brain.
The physical bridge to the central nervous system is gone, which is why the patient cannot feel anything.
However, the long sensory nerve running all the way down the arm is still physically attached to its power source, the DRG. It is still receiving nutrients, so it doesn't undergo Wallerian degeneration.
Wow. It stays alive. It conducts electricity on a diagnostic test, but because it has no pathway to the brain, it is functionally useless.
It's an isolated circuit, perfectly preserved but completely cut off from the world.
That is just mind-blowing. Once the medical team has mapped out these living and dead circuits, the surgical chess match begins, and it becomes incredibly clear from the sources that the surgeon's greatest adversary is a biological clock.
Timing dictates absolutely everything in peripheral nerve surgery. There is a deeply ingrained philosophical debate about when to operate.
Right, like, do you go in early within the first few weeks to definitively explore the damage and start reconstructing?
But the risk there is operating on nerve pathways that might have been only stretched, not completely torn. They could recover spontaneously if given a few months.
But if you wait 3 to 6 months to see if natural recovery happens, you are burning valuable daylight on the biological clock.
And that clock expires at roughly 12 to 18 months. It's an absolute deadline.
The sources detail that if a muscle goes without a neurological signal for a year, the motor end plates, the specific docking stations inside the muscle where the nerve connects, permanently scar over and degenerate.
The muscle tissue itself atrophies and is replaced by fat and fibrous tissue. You could execute the most flawless nerve repair at month 18, and the muscle simply won't respond. The receiving hardware is permanently offline.
That rigid time frame forces surgeons to prioritize. Because an avulsed root cannot be plugged back into the spinal cord central nervous system, tissue does not regenerate, and scar tissue physically blocks the pathway. Surgeons have to find new sources of power to wake up the most critical muscles before they die.
They rely heavily on nerve transfers.
The concept of nerve transfer is astonishing. The surgeon takes a working, slightly redundant nerve, cuts it, and splices it into a dead but vital nerve to bring it back online.
It is the ultimate exercise in bioengineering. The surgical priority is almost always restoring elbow flexion first. If you can bend your elbow, you can bring your hand to your mouth to feed yourself.
Which is basic independence. One of the most famous techniques for this is the Oberlin transfer.
Right. A surgeon opens the patient's arm and locates the ulnar nerve, which is healthy and firing because its lower roots were spared.
And the ulnar nerve has redundant bundles of fibers, or fascicles, controlling wrist and hand flexion.
Exactly. The surgeon dissects out one of those expendable fascicles, cuts it, and reroutes it directly into the paralyzed musculocutaneous nerve, which supplies the bicep.
They are borrowing a wire from the hand circuit to power the elbow circuit. But what if the whole arm is dead in a plexus injury? There are no local nerves to borrow.
That's when things get truly radical. The clinical sources describe using intercostal nerves.
The nerves that wrap around your ribs and flex your chest cavity to help you breathe. Wait, so you can just borrow a nerve that helps you breathe, wire it to your arm, and your brain just figures out how to use it?
Yes. In massive avulsion injuries, the intercostals become the primary donor source. Surgeons will harvest the 3rd through the 6th intercostal nerves from the chest wall, tunnel them under the skin, and wire them directly into the dead nerves of the arm.
This forces you to rethink everything you know about how the brain connects to the body. The surgeon is wiring a nerve meant to expand the rib cage into the bicep.
It relies entirely on neuroplasticity. When the patient wakes up and wants to bend their elbow, they cannot simply think about moving their arm. They literally have to concentrate on taking a deep, forceful breath.
That is insane.
The brain fires the command to the chest wall, the signal travels down the reassigned intercostal nerve, and the bicep contracts. Over months of intense rehabilitation, the brain begins to remap its own motor cortex.
So the physical architecture of the brain actually changes.
Yes, it associates that specific neural pathway with arm movement instead of breathing. Eventually, the patient no longer has to consciously think about taking a breath. They just think about moving their arm, and the newly mapped circuit does the work.
It's an incredible testament to the adaptability of the human nervous system. But what if the patient is referred to a specialist too late? What if they are past that 12-month deadline and the arm muscles have already turned to fibrous tissue?
A nerve transfer won't work anymore. That is when surgeons pivot to free-functioning muscle transfer, or FFMT.
The DOI procedure is the classic multi-stage example of this.
Right. If the arm muscles are dead, you have to import entirely new hardware. The surgical team goes down to the patient's leg and harvests the gracilis muscle.
They take a muscle from the inner thigh, completely detach it, and move it to the arm.
They transplant the entire muscle unit. They anchor one end to the collarbone and attach the other end deep into the tendons of the fingers or the forearm. But moving the muscle is only the first step.
To keep it alive, they have to perform complex microvascular surgery, painstakingly stitching the tiny 1-millimeter arteries and veins of the leg muscle into the blood vessels of the arm under a microscope.
Then they take a donor nerve, often the spinal accessory nerve from the neck, which normally controls shoulder shrugging, and splice it into the nerve of the transplanted gracilis.
So the leg muscle, powered by a neck nerve, is now functioning as the patient's new arm flexor.
Plumbed and wired entirely from scratch.
And if even that level of microsurgery isn't viable, the sources mention salvage procedures like arthrodesis. The surgeons permanently fuse the shoulder joint bones together with plates and screws.
If the intricate network of nerves can't lift the arm independently, fusing the joint allows the patient to use their massive, still functioning back muscles, like the trapezius and rhomboids, to simply hike the entire shoulder blade upward, carrying the fused arm along with it.
It is a mechanical workaround when the biological wiring cannot be salvaged.
Right. It sacrifices mobility for stability, and it can significantly improve a patient's quality of life by preventing the paralyzed arm from constantly dislocating under its own weight.
So what does this all mean? When we look at all of this, we see a nervous system that is deeply fragile, capable of being entirely wiped out by the physics of a motorcycle crash, yet almost miraculously adaptable given the right surgical rerouting.
It really is a marvel. But if we're looking at the entirety of the clinical picture, we have to address a very sobering complication detailed at the very end of the sources: neuropathic pain.
Right. We established earlier that a patient with a panplexus preganglionic injury has a flail, completely numb arm. They receive zero sensory input from it, yet the texts state these patients can suffer from agonizing, debilitating chronic pain.
It is a brutal complication. We tend to think of pain as a signal from an injury traveling up to the brain. But in a root avulsion, the connection is gone. Instead, the trauma to the spinal cord itself and the severed ends of the nerves creates an environment of chaotic, hyperactive electrical signaling.
It's like a severed alarm wire in a building that is short-circuiting, constantly sparking, and sending a fire signal to the monitoring station, even though the room it used to monitor is completely quiet.
A perfect analogy. The central nervous system is misinterpreting that electrical static as severe burning pain in a limb that technically isn't communicating anymore.
And how do they treat that?
To manage this, when medications fail, neurosurgeons sometimes have to perform a DRE's ablation. DRD stands for dorsal root entry zone. The surgeon goes into the spinal cord and uses radiofrequency to literally burn and destroy the microscopic pain pathways where the avulsed root used to attach.
Attempting to silence that short-circuiting alarm.
Exactly. In other cases, they implant deep brain stimulators to try and drown out the chaotic signals before the brain can perceive them as pain.
It forces you to rethink the entire concept of phantom pain, occurring in a limb that is still physically attached to the patient's body but neurologically isolated. It really makes you wonder about the future of this field. We are currently borrowing leg muscles and breathing nerves to piece these patients back together. Imagine looking down at your own arm, commanding it to move, and knowing the signal started in a nerve meant for your chest.
It is a lot to wrap your head around.
It is. Think about where this research goes in the next few decades. Could we eventually develop synthetic neural interfaces to bridge the scar tissue, allowing us to plug avulsed nerves directly back into the spinal cord?
That would be the holy grail.
As the bioengineering advances, we might one day restore the original wiring diagram entirely. We invite you to explore the continuing research in peripheral nerve repair, because beneath these complex anatomical diagrams is a frontier of human resilience and medical ingenuity.